Okay, so the next topic I'm going to share with you today is the role of rheumatoid disorders in development of common morbidities of pregnancy and what we can do as practitioners of women's health to help alleviate or at least lessen the effects of rheumatoid disorders on the pregnancy or vice versa. I have to point out, I always try to give credit where credit is due. Hueppchen has a Center for Lupus and Pregnancy that has been around for several decades now, led by one of our rheumatologists, Michelle Petrie, and one of my mentors in maternal fetal medicine, Dr. Frank Witter. And the body of the literature that's been published on outcomes and therapies, much of which, not all, but much of which I'm going to share with you today, actually comes from a lot of the work they've done in collaborations with colleagues in Europe, and also from their fellows and other faculty members that have sprouted out and gone elsewhere besides Hueppchen and continued the quest of looking at and trying to improve the outcomes of rheumatoid disorders in pregnancy. So the objectives for the session are to appreciate how signs and symptoms of rheumatoid disorders may mimic the signs and symptoms of normal physiologic changes of pregnancy, an important fact, one we may not think about all the time. To classify common rheumatoid disorders and the epidemiologic burden among pregnant women in hopes that we'll all try to stabilize disease before women decide to become pregnant. To understand how the pathophysiology of rheumatoid disorders may trigger maladaptive physiologic responses that can lead to common morbidities in pregnancy, like preterm birth and preeclampsia. And then to value the importance of the multidisciplinary approach to the care of the pregnant patient with a rheumatoid disorder. I tell the medical students all the time, and I think I shared this with you all last year when I was talking about obstetric emergencies, and that's that medicine these days is not an individual sport, it's a team sport, and it requires a lot of different types of physicians, a lot of other allied health professionals to be able to take good care of these very complicated patients, both leading up to pregnancy and through pregnancy. Again, I have no financial conflicts related to this presentation. Joan stuck in pictures of where she lives. I had to put a picture of my daughter in here. This is where my finances go. Any of you that have children who ride horses know that's where your finances go as well. Okay, so what's in a name? So autoimmune disorders or rheumatoid disorders are actually a collection of heterogeneous disorders that are characterized by immunologic reactions against self-antigens that promote antibody and immune complex formation, and those immune complexes then attack tissues, sensitive tissues within the body, leading to a whole host of symptoms and illnesses. I have listed here for you several of the major connective tissue disorders or autoimmune disorders. And again, you can kind of take those terms, systemic autoimmune disorders, rheumatoid disorders, connective tissue disorders, and their definitions are much the same. Because there are so many of them, and we have limited time this morning, I'm going to focus on the top three that are bolded here: lupus, antiphospholipid antibody syndrome, and rheumatoid arthritis. That doesn't lessen the degree with which either pregnancy can affect or the disease can affect pregnancy with the others that are listed here. So to give you a little bit of an idea of the epidemiologic burden, we have found more and more that we have patients with one or overlapping connective tissue disorders in our high-risk obstetric clinics over the last 20 or 30 years. I think when Joan and I were residents, the clinics were filled with diabetic patients and hypertensive patients in high-risk OB. Now we have those, but we also have a large population of patients with various rheumatoid disorders. Not surprising, given that rheumatoid disorders are more predominant in female patients. They're more commonly diagnosed in the childbearing years. And interestingly, when you think about antiphospholipid antibody syndrome, 70% of these individuals are also women. And if they're being diagnosed in the reproductive years, you can understand why this is a huge burden in obstetrics and high risk. And as I mentioned earlier, I alluded to the fact that many of these women have overlapping disorders, of which antiphospholipid antibody syndrome and lupus, for example, is one of the most common overlapping. Because even if they are diagnosed with APS, about 10% of them will go on at some point in time to develop lupus. And that's an important thing to counsel patients about. They may have had antiphospholipid antibody syndrome, for example, diagnosed because of her current pregnancy loss, and someone did the immune testing and said, oh yes, you meet criteria for antiphospholipid antibody syndrome. They may never have had a thrombotic event or any other of the criteria, but they need to know that they are at risk for going on to develop lupus later on. Why is this such a high-risk pregnancy population? Well, one, because pregnancy can increase maternal disease flares. Two, because these flares and the baseline disease itself, particularly if mother conceives when her disease is not stabilized, can have serious adverse fetal outcomes, and because the myriad of therapies that are out there for the various rheumatoid disorders, some of them are potentially teratogenic. And even in those that are approved in pregnancy to manage disease, because if you don't have a healthy mother, you're never going to end up with a baby anyway, will still have some fetal effects. So the question is, why are we seeing more patients with rheumatoid disorders? This is paraphrased from a paper by Saunders in 2007, and I thought this theory was very interesting. Where multiple endemic infectious diseases are low, there seems to be a low incidence of autoimmune disorders, and where there's a low incidence of endemic infectious disease, the incidence of autoimmune disorders is on the rise. Well, so I guess the theory is if your immune system can't attack something external, then it's going to attack itself. I think probably even more likely is that we just have better diagnostic techniques and knowledge of potential therapy to improve outcomes in autoimmune disorders, so it's being diagnosed and addressed more frequently as well. But I do find that a very interesting theory overall. So let's look at the very first objective here and think about it. And I want you to keep these next few slides in mind as we progress through the different types of autoimmune disorders. So this is a very lengthy list of symptoms that are normal in pregnancy that can mimic lupus activity or flares of rheumatoid disorders. And I won't go through each one of those, but again, if you had a non-pregnant patient that had any of these complaints, you'd be working her up for an autoimmune disorder. If you look at the hematologic adaptations, to give you a little bit more detailed view of this, these are all normal changes that can occur in pregnancy hematologically. Those that are highlighted in red, and I might add mild thrombocytopenia as well, are also seen in lupus flares and in other rheumatoid disorder flares. So again, overlap in normal hematologic adaptations and lupus flares. Renal adaptations are very similar. Again, these are all normal physiologic renal adaptations in pregnancy, but especially where protein excretion is concerned, it is also something that you can see in disease flare with autoimmune disorders. So again, extremely important that we keep an eye on these patients and understand that when the patient is pregnant, that we may have a very difficult time sorting out early flares of autoimmune disease versus the normal changes in pregnancy. And that brings us back to the importance of seeing these patients preconceptionally so we know exactly what their baseline is and can follow trends over time. Okay, so let's take a look now at some specific rheumatoid disorders and the pathophysiology that might trigger the adaptive responses. So you can pick your pathology here. We can start with antiphospholipid antibody syndrome. We can start with rheumatoid arthritis or lupus. Any choices here? No choices? Oh, lupus? Okay. Now, the good thing is, how do I circulate to that? I think not having a trackball, we are going to have to march through. It's a good thing you picked lupus. So normally when I'm doing these with a large group, I have multiple ones on there, but I pared it down because of the time frame here today. So I guess for technology reasons, we'll just go through. All right, so starting with lupus. So again, the diagnosis is not uncommon during the women's reproductive years. 10% of women are actually diagnosed during pregnancy or in the postpartum period from a flare postpartum. Why is that? Well, even with the advent of more people having insurance, lots of women in the reproductive age years don't bother going to the doctor at all, unless they're pregnant or they want birth control. So hence the reason we may pick up latent disease, including diabetes and high blood pressure, but autoimmune disorders are another one that may have been there and may have been latent and may have been ignored until the woman shows up pregnant. Laboratory evidence that when we want to diagnose lupus includes getting an ANA. 99% of the time this is going to be elevated. Also look at antibodies for anti-double-stranded DNA, anti-SM immunoglobulins, RMPs, SSA, and SSB. And we're going to talk a little bit about SSA and SSB with regard to fetal effects in a little bit also. This is the same, and you probably already know this is anti-Renal and anti-LOB. Again, the importance of diagnosing this in patients who have symptoms or have any suspicion of having lupus is the fact that the mortality rate in undiagnosed lupus is so very high and can be hastened by the stress of pregnancy. One comment, outside of pregnancy, the most common cause of death is usually infection or renal disease in these lupus patients. In pregnancy, it's usually a cardiac or thrombotic event. These are the patients that you think are doing just fine and they tool along, you're monitoring them closely during pregnancy, you're co-managing them with a rheumatologist or other subspecialists and their primary care physicians. They have their baby, they're walking down the hall, and they have a massive PE and die. Or they develop a cardiomyopathy and have subcardiac death. These are the patients that really scare me. Hemorrhage I can deal with. These are the patients that really scare me because it's not always predictive. So what are the diagnostic criteria other than laboratory criteria for lupus? Again, there are 11 criteria because now, there used to be 10 you recall, and several years ago they made it 11 because they're now including immunologic disorders such as antiphospholipid antibody, anti-DNA or anti-SM antibodies. Those serologic tests are also included now, and you have to have 4 of the 11 to be diagnosed. These criteria, even back in 1982 when they first looked at the sensitivity and specificity in testing lupus versus control patient data, are actually highly sensitive and highly specific for the diagnosis. So the other question is, does pregnancy affect disease course? Well, if you look at this list, it outlines for you the impact of pregnancy itself on lupus activity. We know that the risk of disease activity is 7-fold higher if the patient's disease is active at the time of conception. So again, it really behooves us to try to get our patients with lupus to get their disease under control and stabilized before actually conceiving. In addition, the risk of, if their disease is not stable at the time of conception, of having flares of lupus nephritis can be up to 30% in pregnancy, arthritis flares up to 20%, and thrombocytopenia up to 40%. So again, I can't stress enough, stability at the time of conception is really important. But of course, we're going to miss that whole group of patients who don't get any regular medical care and are actually diagnosed in pregnancy because of a flare. In our system, and it's recommended in the literature also that on a monthly basis during pregnancy, patients' immunologic status is being monitored. And I've listed here for you the labs that we get on a monthly basis, which include the antibodies, looking at complement levels, looking at the antibodies for SSA and SSB to predict fetal effects, looking at lupus anticoagulant, the double-stranded DNA, all the other immunologic testing. One of the things that's really important here, and you'll see, is going to be a differentiating factor in looking at whether a mom's developing preeclampsia in the latter half of pregnancy or whether she's having a flare, are those complement levels. And sometimes that's the only thing, the hypocomplementemia, because the complement's being eaten up in the form of immune complexes. So the free circulating complement is less in a flare, as you know. Because complement levels are induced to increase in pregnancy in terms of natural history, it's very important to be able to see on a monthly basis that increase in complement so that you can compare that if all of a sudden you start to see a decrease in complement as potentially a predictor of an early flare. So hypocomplementemia by itself isn't necessarily going to be the panacea for differentiating obstetric versus lupus morbidity, but you need to look at what's been happening over time, the trending of those complement levels. Certainly kidney function baseline is important and then followed every month. Of note, remember in pregnancy, because of the increased glomerular filtration rate, that creatinine clearance should go up well over 100, usually over 120 in the course of pregnancy. While the 24-hour protein is still written as gold standard, it's very rapidly being replaced by the spot protein creatinine ratio. And if you look at what's normal in pregnancy, again, because of the increased filtration rate, 0.15 or below is considered normal for that protein creatinine spot ratio. But if it's up around 0.3, that may be more indicative of preeclampsia or a flare of lupus activity. So again, important to look at the trending of those ratios over time. Certainly a CBC to look at platelets, liver function tests, and then following the amniotic fluid and fetal growth, looking for poor perfusion of the fetal placental unit. And then for all of these patients, we do antepartum testing, which in addition to serial fetal growth ultrasounds means getting the non-stress tests. And we do them twice a week, beginning usually at 32 weeks. But if a mom is having a flare, we'll go as early as 26, 28 weeks of gestation. Okay, so what are some of the adverse outcomes that can occur with lupus in pregnancy? So first of all, hypertension. These women may come into pregnancy with baseline hypertension in association with their lupus, or they may develop the spectrum of hypertensive diseases in pregnancy during the pregnancy. And the incidence of preeclampsia and eclampsia is as high as 35%. Again, really sort of depending upon what comorbidities she came into the pregnancy with and whether or not her lupus was stable at the time of conception. Preterm delivery is up to 33% in patients with lupus. And again, this is thought to be due to the exaggerated inflammatory response of lupus. And very, very important that, again, I can't stress enough the stability early on, because that's when placentation occurs. And that early formation of the placenta is going to set the stage for what's going to happen later in pregnancy. So if you don't get the increased capacitance at the placental bed level early on in pregnancy because of an exaggerated inflammatory response going on in the body from lupus, you're setting the stage for growth restriction, for possible preterm delivery, and for possible preeclampsia later in pregnancy. Preterm rupture of membranes is more common in these patients, leading to preterm delivery. 30% of them will have premature rupture of membranes, meaning before the onset of labor, not just preterm premature rupture of membranes, but premature rupture of membranes even in term deliveries. Again, thought to be connected physiologically to the inflammatory reaction in lupus. About a third of patients with lupus will end up with cesarean section. Perhaps the theory here is, again, that you have poor uteroplacental perfusion, and these babies perhaps won't tolerate labor as well. And then, while this mortality prevalence seems low, these are usually related, as I mentioned earlier, to cardiac and thrombotic events, particularly the thrombotic events in the peripartum period. So in 2008, Megan Klaus, who was actually a fellow of Michelle Petrie, she's no longer at Hopkins and has a big practice, university practice and research endeavor on her own, did a national study to look at the complications of lupus in pregnancy, and did it over an inpatient sample of 4 years, with the primary outcome being maternal and pregnancy-related complications. And she found that in these patients, maternal mortality was increased sevenfold, up to sevenfold increase in thrombosis, infection, thrombocytopenia, and need for transfusion. There was an increased risk of cesarean section, preterm labor, preeclampsia, all the things we thought were there, but now we have epidemiologic evidence for, and more likely to have other comorbidities. So the effect on practice, based on all of this, should be that the care of these patients, again, should be a team effort with a multidisciplinary team. I mentioned earlier how similar lupus flares were to the development of preeclampsia. So just as a refresher for those of you that don't deal with preeclamptic patients, but you probably remember this from your education, but mild preeclampsia is when the blood pressures are persistently elevated, either systolic or diastolic, doesn't have to be both, greater than 140/90 after 20 weeks. If you're diagnosing persistent hypertension before 20 weeks, it's chronic hypertension, not gestational hypertension. You may have proteinuria, but it's going to be mild proteinuria. Severe preeclampsia is you're adding in higher elevated blood pressures along with evidence of end organ damage. And I might add that while I left fetal growth restriction on here, this has been taken off the list as an official criteria for severe preeclampsia now by the NIH consensus conference that happened a few years back. Many of us are still arguing that fact, but the reason they did that is because it seems to be more multifactorial than once, particularly in these patients that have underlying comorbidities and not just preeclampsia. So if you look at some of these things, comparing a lupus flare to preeclampsia, there are a lot of similarities here. The one thing that stands out is the complement levels and complement activation. So in a lupus flare, when there's more activation of complement and formation of these immune complexes, you're going to see lower complement levels, which you would not see in preeclampsia. That's not to say that you're not going to see superimposed preeclampsia in a lupus patient. You absolutely will. There's a much higher risk. The incidence in a non-lupus patient of preeclampsia in the U.S. is up to about 8%, and it's much higher in lupus patients. If you look at the pathophysiology of preeclampsia, much like we looked at the normal physiologic changes in pregnancy and where some of those changes overlapped with autoimmune disease flares, the same thing you see in red here occurs in the maladaptations seen in preeclampsia, as well as the maladaptations seen in lupus flares. So again, very hard sometimes to sort this out unless you're following the patient closely. Why is that? Well, they probably have a similar physiologic background or physiologic pathogenesis. Initially, as I mentioned, that in that first trimester when that placenta is forming, it's very important that there's increased capacitance in the spiral arterioles at the level of the placental bed. If that doesn't occur because there's an inflammatory response going on at that time, for example, in a lupus flare, what's going to happen is you're going to have an imbalance between these factors, the antiangiogenic and the proangiogenic. You're going to have more antiangiogenic factors, and so you'll have decreased capacitance instead of increased capacitance. Therefore, in the long run, over the course of the pregnancy, it's going to release additional inflammatory factors and have more systemic effect on maternal endothelial function and more vasoconstriction to other organs, leading to other end organ damage. This is the same sort of pathway that happens in a lupus flare. So ultimately, what are we going to do about this, whether we have a lupus flare or whether we have preeclampsia? Well, in lupus, the patient will greatly benefit from increasing doses of steroids to treat the acute flare, plus or minus adding azathioprine, and you might actually be able to avoid a preterm delivery by getting the disease back into a more stable condition. With preeclampsia, however, if it's in the severe category, most often the patient's going to benefit most by delivery before suffering any permanent end organ damage. Although I hesitate to say this, but in later pregnancy, lupus flares, once you begin treating them and you start to see the patient trending towards stability, it may be that if she's been having frequent flares, once you get her stable from the most recent one, and you're beyond 32 to 36 weeks, it might be a good idea just to get her delivered as well, because it's almost inevitable she'll develop superimposed preeclampsia on top of that. So I wanted to mention also the idea of, sort of the ultimate devastation for mothers, short of their own demise, is really the loss of their baby. And so we try to look for early factors in pregnancy loss in these lupus patients. And one of the studies, again by Megan Klaus in 2006, and there have been studies that have reiterated these same findings since then, showed that there are 4 main risk factors in terms of lupus activity, that if we can treat any associated antiphospholipid syndrome along with the lupus, treat the hypertension, we may actually be able to affect a better outcome. And those path or 4 risk factors that were delineated are significant proteinuria, the coexistence of antiphospholipid antibody syndrome, which we'll talk about in a minute, thrombocytopenia less than 150,000, and persistent hypertension, even in mild forms. So looking at the adverse, we talked a lot about the maternal outcomes, but looking at some of the adverse fetal outcomes, growth restriction, well, that's a no-brainer if you have poor placental perfusion. Preterm delivery, that obviously long-term affects the fetus in terms of respiratory, ocular, neurodevelopmental, bowel function, depending upon how early the baby's delivered. Other predictors for preterm delivery or adverse fetal outcomes are frequent lupus flares that require high-dose steroids, because we know that those high-dose steroids can have an effect on the fetal adrenal gland if they're persistently administered in high doses, and also on brain development. With maternal renal disease and hypertension, those risks increase tremendously. Up to 53% of mothers that have underlying renal disease from their lupus and associated hypertension are going to end up delivering preterm, most often because either a failure to growth, so intrauterine growth retardation, or superimposed preeclampsia, or the exaggerated immune response triggering preterm delivery. There also, with renal disease, is a much higher risk of in utero fetal demise or neonatal death. One of the things that, as pediatricians, if any of you take care of the pediatric population, which I'm sure many of you do, that you might have to encounter is neonatal lupus syndrome. So this is seen in those mothers that have positive SSA and SSB antibodies, or Rho and Law, whichever terms you prefer. And it tends to be more prominent if mother is SSA or anti-Rho positive than SSB. So up to 30% of pregnancies with lupus are going to be SSA or SSB or both positive. These are IgG antibodies that can cross the placenta. Remember, only IgG antibodies can cross the placental barrier. They then trigger the fetal immune response, which in turn ends up with cardiac, with cutaneous, with hepatic effects, with thrombocytopenia. And if it happened in a previous pregnancy, about 1/5 or a little more than 20% of subsequent pregnancies will also be affected. And that's important after a mother has already had a baby for her to understand about the prognosis for future pregnancies. Congenital heart block is another effect with neonatal lupus. So in our patients who test positive for SSA or SSB or both, we do serial Dopplers on a weekly basis up to about 26 weeks of pregnancy. So starting around 14, 15 weeks of pregnancy on up to about 16 weeks, we do weekly Dopplers looking for fetal heart block. The idea being that these antibodies interact with the fetal conduction system, resulting in endomyocardial fibrosis and obliteration of the AV node and complete heart block if the fetuses make it to live-born delivery. Those, and many do, those patients are almost necessarily going to need pacers after delivery. So again, I talked about how we follow these patients. They also will need fetal echocardiograms, best done for visualization purposes between 20 and 24 weeks of pregnancy, either by maternal fetal medicine physicians who are trained in echocardiography. And make no mistake, not all of us are certified in fetal echocardiography, the basic views of the heart, but not fetal echocardiography, or by pediatricians who do fetal echocardiography, pediatric cardiologists. There is some potential for improvement if we see heart block by administering dexamethasone, but not in all cases, but it's worth a try. Keep in mind that when we're talking about different types of steroids that we're administering, if we're giving pulse dose or increased high dose steroids to mother, we use prednisolone for her flare activity. Prednisolone is actually inactivated in the placenta, so it doesn't have an effect. Dexamethasone and betamethasone, however, are not inactivated in the placenta, and when they cross, they will have effects on the fetus. You know, we use betamethasone all the time to enhance fetal lung maturity, hence we know it crosses the placenta. Dexamethasone has been shown to be effective in many, but not all cases of patients with neonatal or antenatal evidence of lupus syndrome in treating the heart block. So a brief word about therapy for lupus. So nonsteroidals and low-dose aspirin we know will decrease thromboxane production, which helps with the increased risk for thrombotic events that we know lupus patients have. They may also modulate disease activity, ameliorate symptoms. However, nonsteroidals we typically try to stay away from in the course of pregnancy because of bleeding effects. However, low-dose aspirin, the 80 milligrams per day, is used in these patients across the board after about 10 to 12 weeks of pregnancy because it is very effective at inhibiting platelet cyclooxygenase and therefore platelet activity. Glucocorticoids, as I mentioned, are usually increased in terms of dosage for rapid suppression of inflammation at the time of flares. Sometimes patients with frequent flares need to be on a lower dose therapy throughout their pregnancy. This gets back again to preconception counseling and hoping that the primary care provider and the patient's rheumatologist have worked very hard, much like other comorbidities, to have the patient stabilized on the fewest medications that keeps her disease stable and the lowest dose possible. That will in turn later on help to minimize fetal effects. We should not, however, stop these medications completely unless they're contraindicated, which I'll talk about in a minute. But these medications that are listed here have all been shown to be used safely in pregnancy, particularly if you can keep them at the lowest dose possible to maintain disease prior to conception. Hydrochloroquine or Plaquenil, long safety protocol for use in pregnancy. And the mistake that many physicians and practitioners make is to stop this medication prior to pregnancy in fear of a teratogenic effect. Stopping Plaquenil in particular is associated with a very high flare rate in lupus, so we want to continue that even through the first trimester. Azathioprine and some of the newer immunosuppressives have also been approved in pregnancy, particularly in the patient who's having a flare or has frequent flares. Contraindicated still are the cyclophosphamide, the chlorambucil, and the methotrexate for obvious reasons that we've had drilled into us as teratogens over the years. So I'm going to move now to focus a little bit on antiphospholipid antibody syndrome next. So for any patient that has a known autoimmune disorder, connective tissue disorder, and has not been screened for antiphospholipid antibody syndrome, I find that hard to believe that they wouldn't have, because I think people jump on that pretty much automatically when they diagnose somebody with an autoimmune disorder. But if they hadn't, they should be tested initially in pregnancy. So there are 3 tests that we use. One is the lupus anticoagulant, and that should be positive on 2 or more occasions, at least 12 weeks apart. The other is anticardiolipin antibody, IgM and IgG, not IgA, IgM and IgA. If they're greater than 40 GPLs, they meet on 2 or more occasions, at least 12 weeks apart. That meets criteria, laboratory criteria for antiphospholipid antibodies, antibody syndrome, or the anti-beta 2 glycoprotein antibody. Again, IgG or IgM, not IgA, and greater than 40. With that said, if a patient has, say, recurrent losses, unexplained fetal demises, severe preeclampsia, there's that squishy effect here too. So if those antibody levels are greater than 20 and they have the other obstetric criteria, we may also consider them to have antiphospholipid antibody syndrome with obstetric morbidities. Okay, so adverse outcomes, well, I think thrombosis is pretty obvious, either arterial or venous. Most of them are going to be venous thrombosis. And 2% of these patients with venous thrombosis will be positive for lupus anticoagulant. So this goes back to the idea that really you're supposed to have these serum factors positive, not just with the event, but 12 weeks later after treatment is complete as well, to make sure that they are indeed positive and not just triggered because of the event or the pregnancy. Autoimmune thrombocytopenia is not an uncommon occurrence, along with antiphospholipid antibody syndrome and preeclampsia. These patients are at much increased risk for preeclampsia. So in 2010, there was an article published in Obstetrics and Gynecology, excuse me, on the association of anticardiolipin antibodies with preeclampsia, and it showed that the increased risk was almost 3-fold for preeclampsia in general, mild or severe, and for severe preeclampsia almost 11 times over the baseline incidence in the population. However, the anticardiolipin antibodies themselves were a non-significant test predictor of preeclampsia. So there's an increased risk by the odds ratio, but they're not a good predictor. What about fetal outcomes? So we've all heard the distressing stories of increased fetal loss. In one cohort study, and this again has been repeated multiple times, it showed about 50% of the patients with antiphospholipid antibody syndrome had losses less than 10 weeks. Growth restriction, the incidence is up as high as 30%. And again, I put the question mark there because if there is diagnosed another autoimmune disorder with that, it can go even higher. It's associated with placental insufficiency, which probably is a no-brainer if it's also associated with growth restriction. And certainly preterm delivery, again, probably a no-brainer if there's an exaggerated inflammatory response of the capillary beds. So in terms of therapy in pregnancy, there are 2 schools of thought on this. One, in the US, the American College of OBGYN recommendations, and that goes along with the Society for Maternal Fetal Medicine. And then there's the European League for Rheumatoid Disorders, who has also looked very closely at this. And essentially, they're the same with the exception of where the red arrow is, and I'll go through the things that are the same first. One is that if a patient has antiphospholipid antibody syndrome, so the positive antibodies, along with the history of a stillbirth or recurrent fetal loss, but no venous thrombotic event, she should get prophylactic heparin and low-dose aspirin during pregnancy through 6 weeks postpartum. Okay, that's antiphospholipid antibody syndrome with the history of a stillbirth or recurrent loss, but no thrombotic event. You can, and rather than doing the sub-Q heparin, you could also use enoxaparin, the low molecular weight heparin, which is typically the prophylactic dose we use is 40 milligrams daily. However, and I'll put in my little plug here, if you have a patient on enoxaparin or one of the low molecular weight, you'll remember that the Half-life is about 12 hours compared with the 6 to 8 for the heparin. So we tend to change patients over from the low molecular weight, which is easier to dose, and even if you're doing it therapeutic, easier to keep therapeutic throughout the pregnancy than the heparin is. But we'll change them back to heparin around 36 weeks before they might start going into labor in those last 4 weeks of the pregnancy. The reason there being is that with the shorter half-life, they're more likely to be able to get regional anesthesia and epidural during labor, and they will love you more. With the longer half-life, anesthesiologists, even though the recommendation in all our literature is 12 hours, many of them will push that even further, and that patient will end up being outside the window to get regional anesthesia. So she'll love you much more, even though she might have to chase the heparin a little bit more, but if you change her over in that last month. So going on to the therapy, if a patient has antiphospholipid antibody syndrome and a history of a thrombotic event, she can get prophylactic heparin during the pregnancy and 6 weeks postpartum. And then antiphospholipid antibody syndrome, I'm sorry, that should have been therapeutic on there. Antibody syndrome without history of VTE, clinical surveillance or prophylactic during pregnancy and 6 weeks postpartum. So this one here with the VTE should be therapeutic. I can't believe all the people that looked at this. Nowadays in my institution, you have to have everybody, if you're going to speak outside, they have to look at your PowerPoints ahead of time as well. So someone in your department reviews all of these. I can't believe we all looked at these. Okay, EULAR, on the other hand, their big difference is that they do aspirin plus therapeutic dosing for antiphospholipid antibody syndrome. So we have not spelled out the aspirin here. They have spelled out the aspirin. I will tell you that in practice, we are all putting all our patients with any type of autoimmune disorder on prophylactic aspirin, in addition to whatever else we're going to be treating them with. Okay, really quick word about rheumatoid arthritis. We talked about the 3 biggies: lupus in pregnancy, antiphospholipid antibody syndrome with or without other connective tissue disorders, and rheumatoid arthritis. If you're going to pick an autoimmune disorder to have in pregnancy, this is the one you should pick, because most likely this will go into remission during pregnancy, and rather than having increased flares during pregnancy. Again, this is highlighted by articular and systemic chronic inflammatory disease that leads to joint damage. It's difficult to identify relapses in the 3rd trimester because many of the signs and symptoms of relapses of rheumatoid arthritis are similar to the complaints patients normally have because of their center of gravity being pulled away from the usual and having a lot of hip pain and lower extremity pain, and oftentimes carpal tunnel and wrist pain as well. The postpartum period, however, is a common time for the initial diagnosis in these reproductive age women who have never had this before. So if now they've delivered and the physiologic changes of pregnancy are waning, and all of a sudden now you're having signs and symptoms similar to rheumatoid arthritis, it is a very common time for the initial diagnosis to occur. 75% of patients with rheumatoid arthritis will have their normal sort of natural history of their disease be ameliorated in pregnancy, but up to 90% can have relapsing in the postpartum period in severe form. There's no evidence of increased risk of adverse maternal outcomes with respect to their overall disease. And in terms of fetal outcomes, there is some increased risk for growth restriction and also cesarean section, because if there's been poor uteroplacental perfusion due to an exaggerated inflammatory response, it's likely these babies may not tolerate, particularly the growth restricted ones, labor. And there are some ongoing prospective studies that are actually looking at effects with rheumatoid arthritis on preterm delivery as well. So if we put this all together to summarize the effects of rheumatoid disorders and how they affect pregnancy and how pregnancy affects these disorders, I hopefully have put this one table together that kind of summarizes everything in the data that we talked about here for you. That's a big take-home message. Rheumatoid arthritis, again, That's the one that if you're going to have one of these in pregnancies, you want to have, because there's rare effects on the fetus, and most of them improve in terms of the natural history of their individual disease during pregnancy. Lupus has a 50% flare rate with an increased risk of preeclampsia, preterm delivery, and certainly fetal effects, including neonatal lupus. Antiphospholipid antibody syndrome just exacerbates the already thrombotic state of pregnancy, and so you need to monitor them very closely and prophylax them, if not treat them therapeutically to prevent thrombotic events. And because of thrombotic events in the microvasculature, can cause fetal loss, growth restriction, prematurity, and low birth weight in these babies. And I added this last one. I left it in, rather. I had it in a much longer list previously, and wanted to focus on the top three, but I left in systemic sclerosis because while pregnancy has no major effect on stable disease, and there's no increased frequency of exacerbations, even compared to some of the rest of the autoimmune disorders, there seems to be a higher rate of preterm delivery and thus prematurity and small for gestational age in the fetuses. So for whatever reason, there seems to be a more of an exaggerated inflammatory response that in systemic sclerosis that may lead to preterm labor and delivery. So why is there an increased incidence? Again, if you look at the etiology of preterm birth, all of these things go back to that. Indirect causes would be lupus, for example, or other autoimmune disorders, but the underlying factor for these items in red really are looking at this pathway to preterm birth, focusing mainly on this inflammatory. And if you look at patients with autoimmune disorders, they have an exaggerated response with the inflammatory markers in the maternal serum, much like you would see in patients with preterm, who have preterm birth, but even at higher levels. And when you look at the pathologic specimens, you see an exaggerated inflammatory response in the histology. You see more preterm rupture of membranes and preterm delivery with these patients. So they follow the same pathway, but at an even higher incidence as patients with just benign, I shouldn't say benign, but benign preterm delivery patients who don't have autoimmune disorders or preeclampsia and are delivered preterm. So just like with any other disease, we don't want to be surprised by the storm, and obstetricians and rheumatologists have been looking for years for predictors of disease flares in pregnancy to try to stay on top of them and improve the outcomes for mothers and babies. And this just gives you a smattering of potential predictors that unfortunately haven't completely panned out as being the panacea. So currently, it's still important that we really monitor these patients preconceptionally and monitor them monthly, looking for changes in their disease state. And that requires optimizing outcome by preconception diagnostics and counseling, as well as prophylactic and therapeutic. I didn't focus too much on lupus nephritis, but if you're looking at a patient who has bad lupus, what did you say before? There's bad and there's not so bad? Patients who have lupus, there's bad and there's not so bad there as well. Those that have long-standing lupus nephritis, this is really bad, because these are the patients who not only could die outside of pregnancy. Remember we said renal abnormalities are one of the highest etiologies for death in these lupus patients. But in pregnancy, it's associated with fetal demise and flares even more so. So for a patient whose creatinine is greater than 1.5 milligrams per deciliter, or they have a low creatinine clearance in particular, those two things, it's not recommended that they become pregnant until they're able to bring their disease into a more stable condition. And then, once you've done that, we recommend that you monitor that for 6 months. Not just, okay, fine, this month your labs are normal or relatively normal, go ahead and get pregnant. Other contraindications are listed here, and most of these are contraindications that of diseases or of morbidities of lupus that occur even outside of pregnancy, but we've added one obstetric one here, and that is a patient who's had previous severe preeclampsia or HELP despite having had therapy with aspirin and heparin in previous pregnancies. These patients, we would recommend that they not get pregnant overall, or at least until these issues have resolved. Pregnancy monitoring we talked about, but again, I can't stress enough, this requires an interdisciplinary team. Rheumatology, obstetrics, neonatology, other allied health professionals, and other subspecialties that's needed depending upon the comorbidities of their lupus or autoimmune disorders. We talked already about pregnancy monitoring on preconception on a monthly basis, and the prophylactic and therapeutic actions. So this just gives you an idea that inflammatory arthritis or in lupus, for example, of what the treatments might be in pregnancy, and I think we covered this pretty well. Do not be afraid to use the prednisolone, to use sulfasalazine, and some of the TNF alpha inhibitors in pregnancy if a mother requires those to keep her disease stable prior to pregnancy, because if mother's not stable, you're not going to have a successful fetal outcome. So take-home points, preconception counseling, multidisciplinary care, followed closely, and we will continue to investigate those predictive markers. Okay, the questions are next. Is that correct?
I think so.
Okay. We'll go through these and then I'll take additional questions. Okay, the first question is, I'm going to read them from here because that's pretty small and my eyesight's getting bad, I think. Even worse. A 26-year-old primary woman with a history of systemic lupus is being seen for routine prenatal visit at 26 weeks. She's noticed mild pleuritic chest pains as well as joint and muscle aches for the past 7 days. Her blood pressure is 142/90. Her protein is detected in her urine 3+ on a urinalysis. Which of the following will best confirm the diagnosis of lupus nephritis and distinguish it from preeclampsia in this patient? Hypertension, low circulating complement levels, increased serum creatinine, or increased proteinuria? Okay, very good. So we have almost unanimous. B, low circulating levels of complement. So the others can all occur in preeclampsia, so it's hard to differentiate. Preeclampsia doesn't affect the circulating complement levels, and in fact, in pregnancy, circulating complement levels should continue to increase over time. So it's important to look at that trend on a monthly basis in these patients who have a diagnosis of an autoimmune disorder. The next question is aggressive management of disease flares and rheumatoid disorders, along with maintenance of stable disease, may affect pregnancy outcomes. All of the following medications may be used in pregnancy to treat rheumatoid disorders except glucocorticoids, methotrexate, hydrochloroquine, or azathioprine. Yay, we got 100% on this one. The answer is methotrexate. That doesn't mean that these other medications haven't been shown to have fetal effects. We talked about the glucocorticoid effects. Hydrochloroquine, even though it can be sequestered in the fetus, has not been shown over decades to have any significant fetal effects. And azathioprine, again, you're generally using that when mother's having a flare, so anything that you would worry about in terms of fetal effects are going to be worse if you don't get that flare and that inflammatory response under control. Okay, neonatal lupus, the next question, may occur in infants whose mothers are SSA and or SSB antibody positive. The following are significantly associated with neonatal lupus except A, neonatal thrombotic events, B, SSA or B, IgG antibodies crossing the placenta and triggering the immune response, C, cutaneous lupus, or D, congenital heart block. Okay, we did pretty well on this one, but there are a few more that had questions about this, so we may want to discuss this after we go through the questions. The answer is neonatal thrombotic event. So that is not a significantly known factor within neonatal lupus, whereas neonatal lupus, the whole pathophysiology, is thought to be due to the IgG antibodies crossing the placenta and triggering the fetal immune response, and then cutaneous lupus, the heart block, and other cardiac abnormalities are thought to be part of the neonatal lupus syndrome. Okay, question number 4. Which of the following statements is true regarding how rheumatoid diseases either affects pregnancy or how pregnancy affects rheumatoid disorders, so in either direction? Which is true? A, less than 10% of women with lupus will experience a flare in pregnancy. B, fetuses of pregnant lupus patients with either SSA and or SSB antibodies are at risk for fetal tachyarrhythmia in utero. C, women with antiphospholipid antibody syndrome are at risk for thrombosis, preeclampsia, and LGA, or large for gestational age infants. Excuse me. Or D, among rheumatoid disorders, rheumatoid arthritis has the best prognosis for maternal and fetal outcomes if disease is stable at conception. Oh, very good. So almost everybody got the correct answer, D. Remember, I kept saying over and over, if you're going to pick one, pick rheumatoid arthritis. A is incorrect because it's actually 50%. Oh, thank you so much. It's actually 50% of women will experience a flare of their lupus in pregnancy. Fetuses are at risk for heart block, not tachyarrhythmias, due to SSA and B antibodies. And antiphospholipid antibody syndrome is actually intrauterine growth restriction or small for gestational age, not large infants. And finally, a 30-year-old para0030. So for those of you that may not use parity on an everyday basis, those numbers refer to the first 0 is number of term pregnancies, the second 0 number of preterm deliveries, the third is the number of miscarriages, terminations, or ectopics, and the fourth the 0 there rather than the 3 is for living children. So this is a patient who's had either multiple miscarriages, terminations, or ectopic pregnancies. So her history is complicated by a complicated lupus history and gynecologic history, and she presents for preconception counseling. All of the following are considered contraindications to pregnancy, except, so she was diagnosed 4 months ago during her last lupus flare with severe pulmonary hypertension. B, her baseline serum creatinine is 2.9 milligrams per deciliter. And these are all true, by the way, in her history. C, she underwent a cold knife cone biopsy of her cervix for cervical intraepithelial neoplasia prior to her first pregnancy. D, she is currently taking lisinopril to treat heart failure following her most recent flare. So which of these are considered contraindications to pregnancy? Good, and most people, it looks like, got the correct answer, and that was C. While a cold knife cone biopsy, if it was a significant biopsy, may be associated with cervical insufficiency and early loss or preterm delivery, it is not a contraindication to pregnancy. We can do something about that if we know. The others, however, indicate severe maternal, either pulmonary, renal disease, or cardiac disease, plus she's had a recent flare in the last 6 months, and so it would be contraindicated for her to conceive at this time. Okay. Do we have time for questions? Oh. Any questions? Yes, sir.
When you have the diagnosis, when you make the diagnosis by you make the diagnosis using 2 tests 12 weeks apart. Mm-hmm. Oftentimes these folks present and they're already pregnant. What's your approach at that point?
So you really need to get it postpartum to be able to make that diagnosis. However, if it's over 40, for example, and they have a history of thrombotic events, we have to do this on a case-by-case basis. We have to also, I do this in conjunction with my colleagues in the rheumatologists in that division, and also counseling the patient about potential risks and benefits from treatment. But if she has a strong history for thrombotic events or other pregnancy-associated events and she's positive, we may consider treatment. That's a good question because that's, as we said, a lot of people are diagnosed in pregnancy with lupus, for example. So, but for antiphospholipid antibody syndrome, it's a little bit tougher when you have to get those 12 weeks apart.